everyone to share their questions or any comments.
May I ask a question, Dr. Vaishak?
Yes, sir, please. Yeah.
Because most of the time it gets dislodged, what we call our probe gets dislodged. That's the main reason for hyperthermia in newborns. So anyway, any difference in the way it has been put in our setting and outside, like whether in UK or some other place, because the way it gets dislodged very easily when you, the way I see it here. The baby moves and all those things, and others are actually not very sensitive to it. And also the nurses may not be so much as too early or hourly. So any way of reducing the chance of dislodging of the
Yeah, we've been me and Dr. Sudhin and all the peers have been discussing how to tackle this particular issue of maintaining normothermia in our neonates. And it does, I mean, in the Helix trial and all the high-income countries, they do have a rectal probe, which provides continuous monitoring, temperature monitoring. So I think in our setting, what we can do is certainly we can improve the frequency of the checks, particularly to check if the probe is intact and if it is on the baby itself. And probably we can have a checklist kind of a thing where hourly or 2 hourly the nurse ticks that the probe is secure and the axillary temperature is recorded and is well within the normothermia range. And we can also probably advise on setting the target temperature, I mean the warmer temperature in a slightly lower range, 36 to 36.5 degrees Celsius instead of a higher threshold. So I think really motivating the nurses to improve the monitoring might help, I think.
I think we should have some technology so that the probe stays there. I think the probe, the way it has been attached using some technology innovations has to be done so that
because the micropore is quite weak.
The micropore easily gets off. Like you cannot use other this for adhesives for babies also. So some amount of innovation is needed in case of the number of babies that we have in newborn is around 100. So the nurse, you know, the nurse ratio, baby ratio. So it's one of the busiest newborn nurseries in Kerala, I think South India. So like we have around 100 babies at any time, and so it would be worthwhile if somebody goes into it practically to see whether we can have a probe which does not fall off.
Completely agree. So yes, Dr. Sudhin,
Vaishak, I think both Josephine and Monica are the their neonatal nurses. Josephine, Monica, any ideas on this? Josephine? Monica? Yeah, it's just a big issue even in Helix. We've been thinking about a lot of, even to develop a machine, a device for maintaining therapeutic normothermia. Because of course we can't use therapeutic hypothermia anymore, but we could change that set temperature to normothermia, 36 or 36.5. But it's more difficult to maintain. The larger babies tend to get the hypothermia. And the smaller ones often get on the lower range. But if the probe comes off, that's a big danger because the warmer will overheat. Yeah, we need to come up with something innovative like Ajit says.
What is the management given for hyperthermia?
Sorry, say that again.
What is the management given for hyperthermia?
Well, it's the prevention, like Vaishak said, it's mostly iatrogenic. The moment you have hypothermia, you're increasing brain injury. If it happens, you immediately need to cool down. So in Helix, most babies, by just switching off the radiant warmers or keeping babies naked, we were able to bring the temperatures down. I think only one baby we had to use a cooling machine to bring to normal range. But key thing is in hypothermia, because if it happens, then you cause some brain injury anyway. And Monica, do you want to say something?
Yes. For maintaining the rectal temperature, for the babies who are not on cooling, we use rectal thermometer for them, rectal probe for them, and we make sure that the temperature does not go high above the normal temperature. So whether if it is in the cooling, the cooling machine itself, the tachotherm itself will alarm us. And if it is for the non-cooling baby, we used to monitor every hourly. So we see to it that the baby doesn't go doesn't increase its temperature. So we see to it, we we remove the clothes of the body if it is non-cooling baby, something like that. And we see to that whether the temperature of the AC in the NICU is normal. So we keep on checks, several checks were there, we follow there.
Yes, thanks, Monica. Yeah, in Helix, it was done very rigorously because we had a lot more staff, and those NICUs were more equipped than the current prevent study NICUs. And we use, of course, rectal temperature. But here, I don't think routinely we cannot use rectal. So we like to use a skin mode though. Yeah. Unless in a subgroup of HIE babies, we think about using rectal temperature continuously, like Monica was saying. If you use
that is very easy to use also, sir. Yeah, it can be fixed to the normal pulse oximeter which we use. Nowadays, in all the oximeters we use in NICUs for the baby, they provide the rectal probe also. During our period, we were searching for the rectal probe, and we bought new probes also for that. But nowadays it's not like that. They give provision for it.
Okay.
Dr. Sahana has also mentioned regarding the probe issue, especially when in an ICU, if there are two babies in one single crib, how do we manage that? Do we have any further questions?
That's going to be very difficult. Two babies. Yeah. We need to think about some, I don't know, is it Swati is not joined, isn't it? We've been discussing about an HI corner or something different we need to think about. Because all the efforts are gone on to cooling. We forgot about hypothermia, which is causing more brain injury. And we can improve the outcomes if we have a hold on the hypothermia.
Do we have any other questions from this session? Okay, I think not. So the next session will be again a Q&A session, but we'll include all the questions from, if you have any questions from any of the sessions that we've had today, you can please post it or use the raise hand option to come in and ask them, or even any comments, your thoughts, everything can be shared now. So for this, and it'll be followed by a summary of today's celebrations. So I would like to invite Prof. Arul to chair this session. And just to start off, we have one question from Dr. Dinesh Paswal. So he has asked, have you used Genetry patch, which is applied on the uterus? It monitors both uterine contraction and also fetal heart rate. So,
okay. So I haven't used it myself, unless any other obstetricians have used. I believe this is for fetal monitoring and uterine contractions. There are different models available. Genetry, I think it's from Bangalore, if I'm right, the original company. They have small skin ECG electrodes of the fetus, which you can put it on the maternal abdomen and get the heart rate by the ECG recording and the myometrial contractions. When we studied deeper into that, it is actually catching only about 70 to 80% of the needed fetal heart rate, unless they have improved the outcome now. But for this particular study, the PREVENT study, we didn't go into that because the PREVENT study was in a low setting with normal vaginal, normal labors and so on. So we wanted to stick to intermittent auscultation. And the hospitals already have fetal monitors, so we didn't want to invest money on new monitors with the ECG patches and so on. I hope I'm right in assuming that's for monitoring the fetus and the uterine contractions. Thank you.
Yes, that's right. Yeah, we did explore that, and the issue was the accuracy, because they're claiming to pick up the fetal ECG, and yeah, we're concerned about the accuracy.
There is a follow-up question from Dr. Baswal. Have you used FetoSense?
Sorry, used what?
FetoSense.
It's a non-stress test, basically continuous, it's again being developed by an IIT guy, Mumbai IIT guy. Basically, it's a portable CTG type.
Right. I haven't had any experience with that. At the time we explored, we had only the Huntley Doppler, which was giving the graphic display, and there was another system produced by Ladal, a Norwegian company. It was, and these two are Doppler, which you can walk around or take it around by the midwife for the doctor and monitor. And we selected the Huntley because it gives a graphic display, whereas the Ladal one is much more convenient. You can put it around even the mother's neck and walk around, but it didn't give a graphic display of accelerations and variability, but it just gives some dots, a trend analysis rather than actual graphic display. So we went for the Huntley, and we had a trial evaluation in a couple of centers. And I think even in Velo, we asked Gigi to evaluate. And then based on the users' feedback, we went for the Huntley. But FetoSense, I don't have any experience. And when we explored for intermittent auscultation, we didn't come across that. So maybe something in the future.
So next, Anju has a comment. Anju, do you want to say it? I mean, speak about it, or shall I read out the comment?
Yeah,
About
I'll explain. Like in the NICU, we can see that most of the times the probes will be out. Like the bystander will not be knowing the importance of maintaining the temperature or regarding the probe. So while diaper changing or like changing the dress and all, the probe will go off, and the baby can get hypothermia. So that can be prevented by just explaining. At least we are attaching the probe like that. Thank you.
Any further questions or comments?
I thought Professor Arul.
Yes, Professor Shekaran.
Second year. Yeah. So is it such a problem? Then I was just thinking, just like our CTG monitor, where we put it onto the abdomen of the mother, like a small elastic band or something. If you can make a device sort of thing where you can attach on to the baby's tummy, this probe.
Right, probe.
Rather than,
you mean for the skin?
No. Just like we are attaching the CTG probes onto the mother's abdomen.
Yeah.
Like that, this probe, which is measuring the temperature of the baby or adjusting the temperature, can we have something like that? A small string sort of a thing, small, not much of pressure onto this thing, attached to the tummy of the baby, so that it lets him sit down
Like, yeah, I think Sudin
it is
might be able to answer. It's like when we put the tachograph or ultrasound probe, we have a belt around, which is elastic and you can tighten it as much as you can, but you can tighten it to a degree, as Professor Sekran says, then it'll always remain there instead of a plastic or elastic patch which comes off when there is sweating or something like that. And I think it's a good idea, but I don't know about the pediatrician's viewpoints on that.
Yeah, we could explore. In Vaishak, we got respiratory belt, isn't it? When you do EEG, you put the respiratory belt on, right?
Yeah, exactly. I think that came to my mind when this idea was brought upon. So we do have a belt when we do EEG. The baby's chest and abdomen midway, we have a belt which kind of senses the thoracic movements. So something like that, if we can have to secure the belt, it will be, I mean, the probe, it will be good, I think. Yeah.
Good idea. Thank you.
Thank you so much, Professor Shekhar.
Yeah. No, just I was wondering, initially when we were all actively in that 20,000, 27,000 deliveries at Calicut, you know, the moment baby is hypoxic, we were trying to get the radiant heaters, and it was used very liberally without knowing that hyperthermia is so harmful. I think that practice still goes on. That baby is kept onto the warmer. If now it is available in many of the bigger hospitals, and all the private hospitals are having it. So without knowing that hyperthermia is so dangerous in any hypoxic baby, because of the theory that at that time we were knowing or still being taught, any hypoxic baby will be losing heat so rapidly. And then you have to prevent the loss of heat. That is what our basic knowledge was, till we came to know that the hyperthermia and the cooling treatment and other things. So this practice of putting the baby into warmer or radiant warmer is still going on. And in asphyxiated baby is likely to have HIE. And you may be precipitating that brain injury by putting the baby into the warmer in an over enthusiastic way. So I think we have to teach or tell our colleagues who are using this very frequently, especially in hypoxic babies, it is being used very liberally. So I am afraid that may be producing some of the HIE cases also, as I could learn from you.
Yes, absolutely. I completely agree. It's only last 3 years we become so aware of the dangers of hypothermia. It was same in even 10 years back in the UK. It was same. People used to say, "Oh, HI babies get fever. We need to give paracetamol." Then we realized it's actually the warmer which was causing the fever, not not.
That's right. Professor Arul is there.
Yeah. Well, I think on that point, actually, Professor Shekaran, is interesting because we believe what the company says. So the baby warmer is there, we go and put it on and turn the temperature as we like. But we don't know what the temperature is at the bed level is. In some warmers, of course, there is a probe which measures the bed level, but some it is not available. The cheaper ones, they have only the knob, and then we think it is 36 over 34 or whatever it is. We adjust it and we are happy walking around, whereas the baby is getting heated up at the bottom.
Yes, that's true. There is a discussion regarding the progress of labor after the established second stage of labor, that it may take a long time and no harm is done. That is right. But in practice, especially in a multiparous woman, once she is 5 centimeters dilated and if the head is engaged, delivery may take place very quickly within 2 hours or 2.5 hours, not that 4 or 5 hours it will take. So that is practically what we have seen. The knowledge that we gain now is, even if you allow more time, no harm is done by that allowing that time rather than hurrying for augmentation and other. That's the basic knowledge. But if you could see the chart, the WHO chart or the labor progression chart, you could see many of them are delivering within 2 hours from that 5 centimeter dilatation. So after 5 centimeter, the labor is rather quick. The thing is that you can allow more time. You need not augment the labor. That is the basic principle that we have to follow. But many a time, they will deliver within a short time of 2 or 3 hours from 5 centimeters, especially if she is a primary, I'm in a multi, and if the head is engaged. You may not have time to reach the hospital when the call comes at 6 centimeter. I may take 15 minutes by the time even patient may be delivered. So this is what is happening practically. So we need not say that it is always due to augmentation. Naturally also it can take place. Of course, Professor Arul can give his comment on this progress of labor after 5 centimeters.
No, I think you're right, Professor Shekhar, in the sense, if you look at the WHO study of 10,000 women allowed to progress without any augmentation, without any intervention, quite a number of them delivered in 1 to 2 hours, some of them 4 hours, sometimes 5 hours, and even at 5 centimeters. But the average rate of cervical dilatation at 5 centimeters to go to 6 is about 0.8 hours. Which means about 40 minutes or so. But if you take the standard deviation, then some of them reached 6 centimeters within 10 minutes. And if you do that for 5 to 7, 5 to 8, 5 to 9, 5 to 10, and so on, there quite a number of them will deliver very quickly. But on the average, it's about just under 1 hour. So 5 centimeter will reach 10 centimeter by 3.5 to 4 hours in a multiparous woman. That's the average. And quite a number of them might be 2 hours. Some of them will be 6 hours, 7 hours. But the ethos of the labor guide is actually, if they deliver quickly on their own, that's fine. But if they are not progressing, some of them are very slow, then not to start oxytocin straight away, but to give them more time. Because sometimes 5 to 6 might be slow, but once they reach 6, they shoot up. Sometimes 5 to 7 is slow, then they shoot up. So at 5 centimeters, you give 6 hours, and 6 centimeters, you give 4 hours, and progressively reduce the time for them to reach full dilatation. So if they reach, well and good, like some are fast runners, some are slow runners, depending on the outcome.
Yeah. So the lesson is that we can give time.
Yeah,
we can give time. People need not hurry. That is it.
That's the main reason. Yes.
Thank you, sir.
Thank you.
Nice to see you.
Nice to see you too. Okay.
No further questions.
It sounds like congratulations.
Yes, there's a nice comment from Anju about it'll be good to teach the bystander also regarding the temperature management. Most of the time, the bystanders are unaware about the probe, and while handling a baby, the probe goes off. It's a good point. Yeah.
The other point during that game, the tour of the hospital, I mean the tour of the labor room, which is happening in US and all, but probably their situation is different. I do not know how in labor room like Calicut Medical College, you can have a batch of expectant mothers walking around the labor room, which is may not be very practicable. So, but it is, there is a definite point on that girl's point that they should be knowing what is going to happen. As I mentioned in my opening remark, this is one of the most stressful period or time in a woman's life. And whatever that stress can be reduced, it is going to help. So I think we should think of a tour of the labor room of a batch of pregnant women as much as possible. But that will, along with the husband, that is what is being done in US and all. But here it is all not possible because of the limitations, so many of these limited. So that is a real point that we may have to think about it.
In the UK, Shekhar, and what we do is over the weekend, not during the weekdays. Weekdays are quite busy. On a Sunday, I ask mothers and husbands who want to come and see the labor ward and the setup to put their names down. And there's a register in the antenatal clinic. So they have bookings on this weekend, next weekend, and so on. And they can book up to only 10 couples. And then we allocate a midwife or a doctor to take them around and see what happens, where is the theater, where is the neonatal unit, where is the labor room, etc., etc. So It may not be possible all the time, but if you fix it, I mean, of course, the workload is quite important. You have a lot of deliveries. So, but a lot of mothers might not want to, but those who wish to, at least you can start the toes, and it can be 2 or 3 batches for the day. So morning 8 to 10, 10 to 12, then 12 to 2 and 2 to 4. So you can cover 40 couples or something like that. Hopefully on a Sunday, they are a little bit more relaxed to have this too. So it's done in the antenatal period rather than when they come in labor admission.
So Dr. Jyoti, Dr. Vinay Chandran, and Dr. Sajala has commented saying that this tour can be now even virtual, or we can make a video and show them.
Yeah, it's a good idea. Yeah. If you can't make it actual, then you can make it as virtual so that at least it's something.
Pensida has a question.
Yes, Pallavi. It is like earlier days and all, like nurses used to deliver for a healthy pregnant woman. But after the Lakshya guidelines, it was told like they cannot do it and only the doctors are delivering it. So why can't, because this is a platform like various stakeholders are there. So why don't the government recommend for at least for healthy pregnant women, the midwives can deliver?
So, yeah. Can I come in?
Yes, ma'am.
No, Bensita, there is as per the Lakshya, there is no rule that only the doctor should be delivering.
Okay.
Okay, so there is no rule because it's usually what happens in a medical colleges. There are interns, postgraduates, and all. Initially, when the number of PGs and interns were less, then it used to be even the ANMs were delivering, like midwives.
Yes.
Okay, the so-called that time. But once our doctor number has increased, so they have taken over. That's all. There is no rule.
Yes, ma'am. But the problem is no, ma'am. The nurses over there, that accountability is going off.
Yeah, that's what.
They are sitting back. Yeah.
Yeah. Because see, I mean, off late they have forgotten that delivery.
Yes, that skill is going off.
All. They have restricted themselves to giving the injections and whatever the necessary things to the doctors. That's all.
Yes, ma'am. That's what the main.
Forgotten the art of delivering. That's what.
True, ma'am. So that concept of midwifery is like slowly fading off.
Yes.
I think we had every week.
I think I learned that.
Best midwife and give her a box of chocolates. The best midwife who had delivered more cases. Then they will give you encourage. Sorry, Sir Karan, you were saying something.
No, I was just remembering. In our time, we were told how to take a delivery by the midwives only. But I am afraid the midwifery course is not there in our state.
Yeah.
So that is the situation now. It's a very good, and we wanted to, our federation wanted to reintroduce that. A trained nurse or midwife has to be dedicatedly posted to such a delivery point. That was our recommendation to Government of Kerala. There is no course of midwifery going on. That was one of the very good, helpful group of health workers. Now they are not there. So at least we are planning to have nurses specially trained for labor room activities and to be specially paid as a higher grade nurse in the labor room. That is our recommendation to government. It may not take place because last 3 years nothing is happening because of the pandemic. So hopefully some such should come, especially trained nurse for the labor room. That is the only way. Doctors have increased, but
Sir, can I come in?
Yes, please.
So it's already there is a program by the Government of India, I think.
That's right. Yes.
I think there is a specialization course for nurses after their graduation. It's 1.5 years course. Already the centers have been identified.
Yes.
And there, I don't know what is the status of it now.
Can I come in?
Yes.
Can I explain this actually, because I had rolled it out. So
Yeah.
basically, this is a 1.5 year course which is being run. This is a midwifery course. It has already started and it is throughout the country, let me tell you. And there are centers being identified. So one of the center is the Fernandez Hospital where this is being done. The first batch is already trained, which is, from, 5 states, which has already been trained. These are midwifery educators which we have trained, and they will subsequently go and train the, in their states, the midwives. So already this has started, and I think the government is has earlier when I was there, we had started with 5 institutions. Now the government has identified 14 institutions, and where this will happen. So this is going to be rolled out in all throughout the country.
Thank you. That's excellent news. Thank you.
Can I comment? Yes.
Yes, please.
Yes, central government has taken initiation for training of midwives. Actually, they have selected our college as one of the center in Karnataka. So the central government team came for inspection. So only initial one inspection is over. Maybe if they may start the midwifery course in our college. Central government means twice they have come and inspected. If they agree, they may start that course. So with this midwifery coming into force, then it will be more streamlined things.
Yeah, that's good. That's good news.
So much. If we do not have any further questions, shall we move to the next session? So now, sorry, somebody had a question.
I just wanted to clarify that this course will be under the nursing or medical education. This midwifery course.
This will be under nursing, INC, Indian Nursing Council.
Thank you. So for our next session, I'm very happy to invite Dr. Dinesh Baswal to talk to us about the national implication aspect of our work. So Dr. Baswal served as the Deputy Commissioner in charge of Maternal Health Division at the Ministry of Health and Family Welfare, Government of India, before taking over the role of Maternal and Child Health Nutrition Lead at PATH. So at the Ministry of Health, some of the national level programs he headed include the Pradhan Mantri Surakshit Madratva Abhiyan, Asha and Lakshya programs, and the midwifery program, among others. He has also provided technical support to the ministry in national level policy decisions on maternal health programs. Welcome, sir.
So thank you, Sudhin, Dr. Sudhin and Dr. Pallavi. When this study was being started, actually, I remember Sudhin had got in touch with me, and I found it to be very interesting that and today some of the preliminary findings have been shared. I think it's a step in the right direction, and I think it opens up basically but I hope that this is I understand that this is a 4-year study, and this will go much deeper, and we will get a lot of insight into what exactly and how we can prevent this. I think there are certain questions, which one of the question was about the midwife taking over delivery and what will happen during that period. Another point which is again going to be interesting is that choice of birthing position. Is it going to make a difference? The other is about we started also with delayed cord clamping. That means it's not true delayed cord clamping. It is actually when the you cut the cord when the placenta separates. So does that help basically going more blood to the basically baby? Does it help in that way? I think the future for I have been talking to Sudhin on this, and I think what we have to do is a multi-centric study involving states where this high mortality states, especially Assam, Madhya Pradesh, Uttar Pradesh, and also some of the states where midwife has been rolled out, like for example in Telangana, where midwife has already been rolled out. How does it help and shape up? Also, basically seeing that in one of these states, for example, in Gujarat, we are already doing this, delayed cord clamping, where we are allowing placenta to separate, and then we are actually not cutting the cord. So how does that help? So all this, basically, I don't know how to basically build the design of the study, but I think these are points which needs to be taken into consideration once we are actually moving ahead. I think with this current study, we will be getting more and more insight. Thank you for inviting me, and thank you, for giving me. I was really enlightened with the amount of findings which have been shared with me. Thank you very much.
Thank you so much, sir. Would anybody like to add or make any comments? Okay. So now, thank you all so much. Now I would like to invite Dr. Noor Amin, Associate Professor of Obstetrics and Gynecology at Government Medical College, Calicut, to deliver the vote of thanks.
Thank you, Pallavi. Am I audible?
Yes.
Okay. So Dr. Sudhin had asked me not to just restrict myself to vote of thanks. So I'll take the opportunity now to say a few words about the institution, our institution. So to start with, the organized maternity care in Calicut had a very early beginning in the early part of the 20th century. So first institution that established was the Women's and Child Hospital in 1903. So our institution, the IMCH, was established in 1975. So ever since, it has been a high volume center, just catering to women and child health of a huge population from an extended area around Calicut district. So there were times the institution had an annual deliveries of up to 28,000, which was the highest in Asia. It was what Shekharan sir was talking about. So the important part about all this was the enviable statistics the institution achieved in reducing maternal and infant mortality and morbidity, even with this huge volume, and also amidst the restricted resources. So over the 45 years of its existence, there has been persistent efforts to improve the quality of care, which even today marks out the institution from others. The last few years, there were complete renovations of the labor rooms, the NICUs, the theaters, towards achieving this goal. So coming to the PREVENT trial, it was under these circumstances that we were approached by Dr. Sudhin with the idea of the PREVENT trial, which involved implementation of a pragmatic intrapartum care bundle. Coincidentally, at this same time, we had begun the implementation of the Lakshya program, which was aimed at improving the quality of care in the labor rooms of public institutions in the country. We could see the similarities between both of these, and we were only happy to join the trial also. Ever since we started this, we had the opportunity to gather abundant knowledge of the complexities and challenges by talking to experts from all over the world. Till now, we have been able to use this opportunity to audit our practices, existing practice in the labor room, and also look for places of improvement along with the support of the team. With the implementation of the care bundle, we hope to achieve this goal of improving the neonatal outcome and also to provide our mothers with a positive childbirth experience. So we would like to thank Dr. Sudhin and all of PREVENT team members for the wonderful experience we have had in interacting and working with them. So coming to today's program, I express our sincere thanks with appreciation for a wonderful organization of today's program through all the additional challenges they had to face because of the COVID wave is actually sweeping through these parts now. So a lot of changes had to be made from the initial plans due to the evolving situation, which they did very smoothly. I mean, meetings should finally materialize. Who also being in such circumstances were kind enough to still take part in the program today and speak on very important topics. These, as always, has brought us lots of knowledge with wisdom from all of their rich experiences, which we truly value. So our special thanks is also to Principal, Government Medical College, Calicut, and the Superintendent IMCH for all the supports they have always given us throughout. And also, they could not address today because of their busy schedule, but we thank them for all the support. So I also take this opportunity to thank the audiovisual team and other technical team members and each and every person who have helped us today in organizing this event. Last but not the least, thanking all the attendees of this program from all the parts of the world. And we all hope all of us have gained immensely today by listening to the experts. And this makes all the efforts worthwhile and this program a success. We also thank the patients who attended this meeting, which really added a uniqueness and also was much needed in discussing a topic like this. There was a very good thought to add it. So I express my thanks to everybody. Thank you.
Thank you so much, sir. Now, may I invite Professor Arul to make a closing remark?
Thank you very much, Sudin, team, Nurul, Professor Shekaran, Pallavi. I mean, so many people. I just look at the correspondent and the unity of the Prevent team in the WhatsApp application, and I'm amazed at the way you are functioning. And as I mentioned from Sudin's summary given to me about the progress, we have done very well. And I think one of the things which really strikes me is that there is some research which is going on which might change the whole world, can change their practice. Because so far, although the labor care guide was introduced by WHO, there is no controlled studies to show its benefits. So this is something which is worthwhile, whether we manage labor differently with respectful care, companionship, all these board games and so on. Second, if we can decrease the cesarean section rate by this application of the care bundle, that'll be a great success. And thirdly, but most importantly, how we can reduce HIE and the incidence of epilepsy as planned by Sudin at the very beginning. So I think we are all very happy with the progress, and we all should be proud that we are participating in this study. And I think if this generation of clinicians and researchers and midwives and administrators, if we can do something which will serve the community in the next generation, is to reduce the number of babies born with HIE, cerebral palsy, and epilepsy. So I would like to thank you all really for participating, and thanks Sudin for bringing the research into Kerala and to Bangalore. And I wish everyone the very best, and have a pleasant day today, but continue working hard. Thank you.
Thank you so much, Professor Arul.
Thank you.
Now, we also have Dr. Mohandas Nair, who has joined us, who is the Professor and HOD of Pediatrics at Government Medical College, Idukki. So would you, I invite you to share a few words.
Hello.
Yes, sir.
I could not be with the program throughout. So I will definitely go through the YouTube recordings. Initial part I was there, and it was really touching to hear the mother who lost her baby. And I think we should work hard together to improve the situation. So wishing all the best, and I will be also with you. Thank you.
Yes, thank you so much, sir. So I would like to thank each and every one of you who joined this session for this very, enlightening and insightful session, and especially the parents who made time to join us and share their experiences and views. So I thank all of you on behalf of the Prevent team. Thank you so much.
Pallavi, can I come in?
Oh, sure,
Just
sure. Yes, please.
Just a minute. It's a very, very well organized program. It was. See, we were missing that it didn't happen in Bangalore. Anyway, it was like happening in Bangalore only. And thank you very much. Thank you to the whole team, Dr. Sudin, Dr. Arul sir, and everyone for making it so wonderful program. And we hope to do the best. And it's such a nice initiative. If we can change the whole system of the labor room, it will be really wonderful. Thank you so much.
Thank you so much, ma'am. May I, before everybody leaves, may I please request everyone to switch on their cameras for a few minutes. We'll try to take a few pictures. Harini, can I also take your help with this? Vaishak, you also, please. Thank you. Yes. Yes, I've got them. Thank you so much. Thank you so much for your time. Thank you.
Bye. Thank you, Pallavi.
Bye-bye. Take
Great
care.
session. Yes. Bye.
Thanks, ma'am.
Thank
Bye.
you. Thank you very much. Bye.